I'm tired, but I'm going to do 4 more, but very brief in just this one. So diabetes insipidus. Insipidus is too much, right? So with this one, you expect polyuria, polydipsia, you know, and hypernatremia because water is limited here. So unlike SIADH, which takes in a lot of water, this one, you lose it because you are lacking ADH, right? So with DI or diabetic insipidus, you have 2 types. You have central DI and nephrogenic DI, right? Of course, you've got your gestational diabetes insipidus and stuff, but the main thing here is for you to be able to differentiate these ones, as well as differentiate from primary polydipsia as well. So you can, with fluid restriction, your primary will respond, but the central DI and nephrogenic won't respond. And then to differentiate central DI from nephrogenic DI, you will then give desmopressin, the synthetic desmopressin, and the central one will respond, whereas the nephrogenic won't. So that's how you kind of differentiate until you get to your diagnosis of which one specifically. The drugs that can actually induce this, you need to think of lithium and some of your chemotherapy drugs as well. What else? Yeah, treatment, we've said desmopressin for central DI, and then for nephrogenic you can use like endomethacin and some thiazides. Yeah, why thiazides? Because they are calcium sparing, and where calcium goes as well, water will come along, and then we can hold on to our water. Not just the calcium reasoning, I think they also tend to hold on to water. Gestational diabetes insipidus, I don't really want to talk about it, but this one is just the sustained aminopeptidase enzyme will degrade oxytocin to prevent the uterine contractions during pregnancy. Ouch. Sorry, guys. And so oxytocin looks like ADH. So then it will also degrade ADH. So this is where we get the gestational diabetes insipidus. Done with DI. Hashimotos thyroiditis. This one, think of a woman who is in her 40, 45. The TH is down. Hash, down. And there is a genetic component here. Do we say genetic? Autoimmunity. So the anti-TPOs will be positive in this case. TSH will be high. So you need to be able to recognize a case of this one. Obviously, the most common cause of hypothyroidism is Hashimoto's thyroiditis. Treatment, levothyroxine or levothyroxine with liothyronine. Yeah, so the pathology here is just progressive autoimmune destruction of the thyroid gland, right? So you get a lymphocytic infiltration causing tissue damage and then altering the function of the thyroid gland. So the injury is caused when these autoantibodies and or sensitized T cells react with the thyroid cells, causing the inflammatory reaction and in some cases cell lysis. T lymphocytes are the main cell type here infiltrating the gland. What did I want to say? Yeah, because T4 is down, TSH is up. Now, if you look at the functions of TSH, it's got the synthetic building, this enlarging, number increasing. That's TSH. That's why you might have goiter presentation in these people. Toxic multinodular goiter. This one, multinodular, right? So with goiter, you might have I'm sorry, guys. 2 minutes. Toxic multinodular goiter. So this one, you need to it's a differential for your hyperthyroid states. In this one, your T3 or T4 will be high. What else? I'm actually just double check, but T3 obviously will be higher than T4 apparently, because sometimes T4 is normal. TSH will be down though. And with this one, you have like your thyroid nodules, or obviously multiple nodules, because it's multinodular, right? Multiple nodules when you palpate. And then you also want to differentiate a hot versus a cold nodule versus Graves nodules, of course. So with this one, as soon as you've palpated and you palpate the nodules, the next step is a thyroid scan and uptake test. I'm really tired and I'm struggling. 2 more minutes. So toxic multinodular goiter is actually similar to Graves' disease, but you need to differentiate, okay, these two. Graves, because it's also a hyperthyroid state, but with Graves you will have those specific symptoms like exophthalmos, where the eyes are bulging out. Yeah, so in terms of these thyroid glands, the multinodular goiter is the most common, because then you also have your uninodulars. Okay, carcinoid syndrome, be able to recognize somebody with flushing, blah blah blah, carcinoid syndrome, right? So with this one, you will have symptoms of diarrhea, flushing, edema, abdominal cramping, bronchospasms, niacin deficiency. But the way you diagnose carcinoid syndrome, apart from the symptoms, you can also have increased 24-hour urinary 5-HIAA, which is that serotonin metabolite. So biologically, the active amines and peptides entering the systemic circulation and escaping first pass metabolism. So that's how come we have this. So they escape the first pass metabolism of the liver, usually maybe because of an inactivated liver, right? So most of the clinical features are due to serotonin, which is an end product of tryptophan metabolism. So you also can have like symptoms of tricuspid or pulmonic valve disease, shortness of breath, heart murmurs. Treatment of this one, you will use like somatostatin analogs like octreotide and lanreotide. Trying to pronounce, because they will inhibit the release of GIT and endohormones. Or surgical treatment or elective cholecystectomy is usually part of the treatment because of biliary sludging, and gallstones can occur with the somatostatin analog therapy. Yeah, bye. I'm tired.